So good evening guys, if I'm visible and audible, please give me a thumbs up. Okay, so good evening everyone. So just give me a thumbs up and then we'll start with the session. So I'm just waiting for a thumbs up from someone and then I'll start with everything. Okay, so we'll just wait for people to join in and then we'll start with the session. Right, so I'll just start with the session. If there are any questions or doubts, you can ask me guys. So I'm just not able to see the messages. Okay, so anyways, let me start with the session. In between, if there are any questions, if there are any doubts, you can go ahead and ask me, right? So welcome to this series guys. This is the INICET Sure Shot NEET PG 2023 and today we will be discussing the questions from anesthesia. Even before I go forward to discuss the type of questions which we are discussing, this session is basically going to be MCQs and these are basically previous year's MCQs, previous year's questions. Based on that, we will be discussing our previous year's topics also, right? So basically the questions which are there, based on that a small discussion on the topics so that we are aware of things. Okay, now so going forward guys, just to introduce myself to you, if there are any questions or doubts, you can ask me. Otherwise I'll be discussing the questions, I'll discuss their answers and I'll tell you the reasons as to why which is the correct answer. So my name is Dr. Vinish Shrivastava. Presently I'm the head of the department, Associate Director of Anesthesia and Critical Care, working in Delhi. Before this, I was a senior consultant for about 8 to 10 years. Before that, I was a senior resident at Maulana Azad Medical College. I'm also associate professor at Maulana Azad Medical College after doing my senior residency. Before that, I've done my DNB secondary anesthesia. That's from Deen Dayal Upadhyay Government Hospital, New Delhi. Before that, I've done my DA and FCPS from Grant Medical College, Mumbai. Before that, I've done my respiratory medicine from 𝐒𝐿𝐻 𝐻𝐿𝐻 Municipal Medical College, Sion Hospital, Mumbai. Alright, before that hospital administration and before that MBBS. That was a slight introduction about myself. Also, I've been teaching for almost 13 years now. Okay, so going forward, any questions, any doubts guys, please ask me directly. So this is the first question that we'll take. Arrange the following anesthetic agents based on their potency. So what are the ones that we are supposed to arrange? Nitrous oxide, halothane, isoflurane, methoxyflurane. The options given to us is the first one, option A, methoxyflurane followed by halothane, isoflurane and nitrous oxide. Methoxyflurane followed by isoflurane, halothane, nitrous oxide. Followed the third option, option C, is methoxyflurane, nitrous oxide, halothane and isoflurane. And the last one is halothane, isoflurane, nitrous and methoxyflurane. So this question is basically arrangement of the following anesthetic agents that we have based on the potency. Alright. Now, which is the correct option over here from A, B, C and D? So before we go forward, just remember from the options that are presented to us, Remember methoxyfluorane, M for methoxyfluorane, M for most potent, right? So therefore A, B or C, anything can be correct. Second option, nitrous oxide, N for nitrous, N for not potent, right? So therefore the last is nitrous oxide. So you will find option B, A and B. So C is ruled out. So now option D was ruled out because methoxyfluorane is given last. Option C is ruled out because nitrous oxide is not potent. So the two options that we have left with us is option A and B. And out of them, remember halothane is more potent than isoflurane. Therefore, the correct answer to this question is option A. Okay, option A. What is this based upon? So this is based upon potency. The question is about the anesthetic agents, and this is about the minimum alveolar concentration. Okay, so anesthetic agents based on their potency, if we are discussing, it is about the minimum alveolar concentration. Okay, if there are any questions or doubts, you can ask me in between, guys. Okay, so we are discussing about the minimum alveolar concentration. What is minimum alveolar concentration? So minimum alveolar concentration is the amount of inhalational needed in the alveoli at 1 atmospheric pressure, at which 1 atmospheric pressure, at which 50% of the patients do not respond to surgical or painful stimuli. Right? So, what is the minimum amount of inhalational that is needed in the alveoli at 1 atmospheric pressure, at which 50% of the patients do not respond to surgical or painful stimuli? So, if we are discussing about 6 agents, for all the 6 agents, the amount is going to be different. For example, if I take methoxyfluorane, the amount of methoxyfluorane needed to prevent the response to painful stimuli will be an amount X. If we take halothane, the amount will be Y. If we take isoflurane, the amount will be Z, right? Similarly, if we take nitrous oxide, the amount will be something else, right? So each agent will be needing different amount, right, to make a patient not respond to surgical or painful stimuli, and this is what is called minimum alveolar concentration. So this is the definition of minimum alveolar concentration, and minimum alveolar concentration tells us potency, right? How does it tell us potency? So potency, right? So we have discussed about the 4 agents: methoxyfluorane, halothane, isoflurane, nitrous oxide. So these are the various minimum alveolar concentration needed by each of them. Let's not go into the individual values. It is difficult to remember many a time, so we'll forget that out. Now, methoxyfluorane, the minimum amount needed, right, to produce immobility in 50% of the patients is 0.16%. With nitrous oxide, you would be needing 104%. Do you see the difference? With methoxyfluorane, only 0.16%, which means a minuscule amount of methoxyfluorane is sufficient. Minuscule amount is sufficient for a patient not to move, and nitrous oxide would need 104%, desflurane would need 6%. So which means minimum alveolar concentration of methoxyfluorane is less, but for nitrous oxide is high, which means if you take less amount of methoxyfluorane, 50% of the patients will not respond to surgical or painful stimuli. If you take nitrous oxide, high amounts would be needed to make a patient not move to surgical or painful stimuli. So basically, which means nitrous oxide in high amounts is needed, while methoxyfluorane in less amount is needed, which means minimum alveolar concentration is inversely proportional to potency. So it basically is telling you how much amount is needed by which of the individual agents. Nitrous oxide will need huge amounts for a patient to prevent immobility in that patient, and methoxyfluorane will need very less amount to produce immobility in a patient. Therefore, remember, lower the minimum alveolar concentration, more potent is the agent, and which we have already derived that minimum alveolar concentration is inversely proportional to potency. That's the theoretical part of it. But how to remember for the exam? So if we have to remember the same thing for the exam, a simple way to remember is that when we speak of minimum alveolar concentration, we already know that it is inversely proportional to potency. How do you remember? Remember, at one end of the spectrum, we get methoxyfluorane, M for methoxyfluorane, M for most potent, At the other end of the spectrum, we have nitrous oxide, not potent. Okay, so remember it like this. In between, we just write halothane, isoflurane, sevoflurane, and desflurane, and this becomes our sequential arrangement for minimum alveolar concentration or potency, whereby you will find that methoxyflurane is the most potent agent in terms of the arrangement of potency, and nitrous oxide is the least potent agent in terms of potency, and this would become the arrangement of the sequential order, right? We will do the same thing when we discuss another property from here, which is called as blood gas solubility, right? Another important topic here itself. We are discussing these topics and this is an important one. So when we discuss about blood gas solubility, remember blood gas solubility tells you onset of action, and is again inversely proportional to onset, and it is inversely proportional to recovery as well. Okay, onset and recovery, that is blood gas solubility or blood gas coefficient. Here also we'll use the same thing to make things easy for us. What we are doing is we take the same thing, methoxyflurane at one end, we keep nitrous oxide at the other end, but yes, we'll make one change. We'll put desflurane on this side. That's the only thing that we have done. So now what we have done is we've kept halothane, we've kept isoflurane, we kept sevoflurane. Next to it lies nitrous oxide, and then we have desflurane, and then we arrange it in this order. This becomes the sequential arrangement for onset of action, where you find methoxyflurane, there it was most potent, here it is most slow. Most slow means slowest acting. So therefore you find methoxyflurane to be the slowest onset and slowest recovery. Desflurane on the other hand is the fastest onset and fastest recovery, and this would become a sequential arrangement in this order. Okay, so any questions and doubts, guys, ask me. So this is about the minimum alveolar concentration and the blood gas solubility. Both are very important points. This is a sequential arrangement. This has been asked in the exam. Okay, any questions and doubts, right? So the correct answer to that question, previous year question, was option A, where we found methoxyflurane, the same thing that we have discussed, then halothane, isoflurane, and nitrous oxide in the end. Thumbs up, guys. Any questions and doubts? I've been just looking down at the comment section. Right, so any questions and doubts, please ask me, else I'll go forward. Okay, so if there's something, I am unable to see the messages actually, so let me go forward. Fine. All right, so the next question, let's take the next one. So I was just waiting if someone had a doubt. I would have cleared it out, but no doubt. Okay, so we've discussed 2 points over here. The next question. All right, if you mark out the answers, then we'll discuss in terms of, you know, the T&D, like how we do test and discussions. We can discuss the same way out. Which of the following local anesthetics causes hypertension? A is cocaine, B is lignocaine, C is bupivacaine, and D is prilocaine. Right, so which is the answer, guys? Anyone? Just mark out the answer. Is it A, B, C, or D? Yes, yes, yes. So if you mark an answer, at least I'll come to know. Yes, so target aims says B. Anyone else? Doctor, target aims. Doctor, target aims. No, B is not the right answer. I'll give you one more option, but that does not happen in aims, huh? Remember that. C, it is cocaine. Let me give the answer. Okay, the correct answer is cocaine. First of all, just remember, when we discuss local anesthetics, remember local anesthetics, most of them are vasodilators. Vasodilator, right? Cocaine is the only one which is a vasoconstrictor. So when you will see out of all the options given to you, remember here, lignocaine, bupivacaine, prilocaine, all these are local anesthetics. In fact, even cocaine, right? All these are local anesthetics, right? All the local anesthetics, they have a property. And what is the property? All the local anesthetics have a property that they cause vasodilation. So whenever you are injecting local anesthesia, guys, remember we inject it into the tissue, and from the tissue it gets absorbed inside the nerve. But remember, close to the nerve there are blood vessels also, right? So what happens is when you've injected local anesthesia, all of them are having basically vasodilating properties except 3 of them, and that's the point. Which are the 3 of them which do not have a vasodilating property? So remember, vasoconstrictors in local anesthesia drugs are 3, right? So when we discuss vasoconstrictors, okay, local anesthesia vasoconstrictors, remember there is cocaine, right? The branch is made up of cocaine, guys, we can't help it, okay? So cocaine, remember cocaine was the first local anesthetic ever used. It is the only naturally occurring, right? It's a naturally occurring local anesthesia drug. Apart from that, you get ropivacaine, which has got slight vasoconstricting properties, and you have the levobupivacaine, not the normal bupivacaine. This is the levobupivacaine, which has vasoconstricting properties. So these are 3 vasoconstrictors. Remember, apart from that, all other local anesthesia drugs are vasodilator. Remember, that is the reason why you have a drug called lignocaine plus adrenaline, because normally whenever you are giving local anesthesia drugs, they have vasodilating properties, so the action on the nerve decreases. That is why you always get local anesthesia plus vasoconstricting. For vasoconstriction we use adrenaline or we use phenylephrine. That is the reason, because most of the local anesthesia drugs are vasodilators, so the effect decreases. So we use local anesthesia drugs combined with adrenaline or phenylephrine, right? That's the reason. Thumbs up, guys. So the point here was, which of the following would have caused hypertension, and from them the correct answer is cocaine compared to others. It's not lignocaine, it's not bupivacaine, it's not prilocaine, right? So these 3 drugs are normally vasodilators. This is the only one which is a vasoconstrictor, right? These 3 that you find, these will become vasodilator. Thumbs up, guys. Anyone, any question, any doubt? Dr. Target, AIMS, other people? Right, so I'll go forward to the next question and we'll take it this way. If there's any doubt, you can ask me in between. I'll try to solve them to the best of my ability. Okay? Okay? Okay, so going forward, no questions as of now. Let's take the next one. Simple questions, but at times, you know, the questions that have come, you have to use your mind slightly. This is the next question which is there. Which of the following is required for the cannulation of a newborn? 22 gauge needle, 24 gauge needle, 5 ml syringe, adhesive tape, normal saline. Yes. Option A is when you have 1, 3, 4 and 5. Option B is when you have 2, 3, 4, 5. Option C is when you have 2 and 4. Option D is you have 1 and 4. Right? So yes, guys, anyone would like to say the answer for this question? Simple one. Yes, is it or is it not? Just waiting for options from your end. Otherwise, I'll give the answer. Okay. Anyone? So let me go forward. So out of the points which are given to us, 22 gauge, 24 gauge, 5 ml syringe, adhesive tape and normal saline, you are taking IV cannula of a newborn, right? Small baby, you're taking IV cannula, right? For IV cannula, would you need a syringe with saline? Yes, I will need a syringe with saline. You will need adhesive tape? Yes, I will need adhesive tape. You will need it. Otherwise, how you will stick it? It's a small baby, right? For adults also you will need it, not just for a baby, but for an adult as well. So remember, adhesive tape, normal saline, 5 ml syringe are already needed. All 3 of them would be needed, right? So there is a syringe, there is the adhesive tape, there is a normal saline which is kept over here. All the 3 are needed. But when it comes to taking a cannula in a newborn, remember, the size of the IV cannula, 22 gauge is this, which is the blue colored one. Okay, so the blue colored is the one which is 22 gauge. Yellow colored one is the 24 gauge. This is what is used in pediatric patients, in neonates, guys. So therefore, in a small baby, if you're taking out of the 2 options given to us, I will use a 24 gauge. 22 gauge normally is used for a pediatric patient or used for adult. So therefore, the 22 gauge cannot be or is not used in a newborn baby. So which is the correct answer for me over here? It's option B. 2, 3, 4 and 5. They are all needed, but option 1, right, the number 1 is not needed, because this number 1, which is the 22 gauge needle, is normally used in adult, in whom it is difficult, in adult, whereas there is a difficult cannulation, or used in a pediatric patient. But 24 and 5 ml syringe, right? 24 gauge needle, 5 ml syringe, adhesive tape, normal saline are all needed for a newborn, right? So this is the question is based on IV cannula. Let's go forward. Okay, so when you're discussing about this IV cannula, remember the most common IV cannula which is used in an adult is a 20 gauge. Is this 20 gauge IV cannula? Most commonly used. When it becomes difficult to cannulate with a 20 gauge cannula, we shift over to a 22 one. It's slightly smaller, much more easy. It can be used in adult, it can be used in pediatric. A 24 gauge is what is used in a neonate, and there's another one which is 26, which is purple in color. Purple in color. This is used for a preterm or a preterm neonate. You can use this one as well. The three which you see, 18, 14 and 16, these are thick ones. So remember, these are thin gauge, and this one, these three are thick gauge. The thick gauge are the ones which are normally would be used in whenever you want to give fluid resuscitation, or if you're supposed to give blood to a patient, right? So this is used for blood transfusion or fluid resuscitation, the thicker ones, because the flow rate is high. You'll find the flow rate for a pink one is almost 50-54, right? For the green one is around 80 to 100, for a grey one is 180 to 200, and for an orange one is 270 to 300. Okay, almost like that. On the other hand, you'll find the thin ones, 22 gauge is around 33 ml per minute, and you'll find the yellow one around 20 ml per minute. So this is the flow rate also. So these are the thin ones, these are the thick ones. The most common use is 20. For a pediatric patient, we use 22, or an adult patient where it is difficult, 24 for a neonate, 26 for a preterm, and 14, 16 and 18 are used for fluid resuscitation or blood transfusion. Alright, so the correct answer to this question is option B. For a newborn, I'll be using 24 gauge needle, 5 ml syringe, adhesive tape and normal saline. Thank you. Right, question number 2 done. Question number 3, let's go there. So anyone? Yes guys. The question here is identify the incorrect statement in rapid sequence intubation. Option A, pre-oxygenation with 100% oxygen for 3 minutes is done. High volume, low pressure cuff is used. Okay. Option C, it is the method of choice in a cardiac arrest patient. Option D, induction agent and muscle laxant are given simultaneously. Yes. So which according to you is the incorrect statement? Anyone? Which is the incorrect statement? Yes guys, anyone? Which out of them is the incorrect statement? So in between I can see some answers, in between I can't see some answers. I'm just waiting for the answers for you from you guys. Option C. No, that's not the correct answer. The incorrect statement over here is not option C. Right, so I get one answer over here from Dr. Shukra Singh, and option C is not the right answer. So we are discussing rapid sequence intubation. Alright, pre-oxygenation with 100% oxygen for 3 minutes is done. Yes. A high volume, low pressure cuff is used. Yes. Induction agent and muscle laxant given simultaneously. Yes. Is it the method of choice in a cardiac arrest patient? No. Normally I would like to say, because yes, there's a confusion between two options over here, between option C and D, correctly pointed out as been marked by one of the students over there. Right, so what happens is, in cardiac arrest, the patient is dying. Patient is already dead. So basically a cardiac arrest patient is someone who has no response, who has no pulse, who has no breath. In this patient, if I want to intubate, why will I wait for a cricoid pressure? In a patient like this, I will immediately intubate and I will immediately do CPR. So cricoid pressure giving rapid sequence induction is not so important in a patient like this. What is the meaning of a rapid sequence intubation and where is it done? A rapid sequence intubation is done when a patient is full stomach, right? This is done in a full stomach patient. In a full stomach patient, the biggest problem is the regurgitation of stomach contents, and the stomach contents have come up and they've got inside the lung. The aspiration, right? This is called as the aspiration of stomach contents in a full stomach patient. So whenever a full stomach patient is coming for surgery and I need to intubate the patient, means I need to put an endotracheal tube. So the biggest problem in a patient like this would be regurgitation of the stomach contents and their aspiration inside the lungs. Hence, I need to put an endotracheal tube. But the problem is if I'm trying to put an endotracheal tube, all this will go inside the lung. So what to do? I need to prevent that. So for that, I will be giving cricoid pressure. Cricoid pressure, remember cricoid is the only complete ring in the trachea. Rest all are half rings. So I'll be compressing the cricoid of the patient in such a way that it gets compressed along the vertebral body at the back, under the vertebra. And if you can see, the esophagus has got compressed. This is what shuts off the esophagus. So if there is any regurgitation happening, it will get stopped over here and the further regurgitation will be avoided. Okay, so therefore cricoid pressure has to be given. But remember, this is not being done for a cardiac arrest patient. The whole point of rapid sequence induction or rapid sequence intubation is to be done for a full stomach patient coming for surgery. It is not about the full stomach patient coming for CPR. That is the point. A lot of people do say yes, in CPR do rapid sequence induction, but during CPR, my point to think about it, there are always two schools of thoughts. According to me, if a patient is dying, patient is not breathing, in that case, why will you waste your time doing a cricoid pressure? Just intubate the patient, start the CPR, because here it's more important to save the life. But if a patient is normal, he is not under cardiac arrest and he's come for surgery, that is where you want to avoid that further complication. So this is the point that in a patient of full stomach, what happens is bag mask ventilation is contraindicated. Alright, you can't be giving bag mask because in a patient like this who's full stomach, if I give a bag mask ventilation, I hold a mask on the face and I give IPPV. What happens is some amount of air goes inside the stomach, some amount of air goes inside the lung, and the amount of air which has gone inside the stomach will further inflate the stomach and cause regurgitation and aspiration. I want to prevent that. So therefore, the first thing is that I need to intubate the patient as fast as possible. The first step is to always pre-oxygenate the patient, and pre-oxygenation means give 100% oxygen for 3 to 5 minutes. So I'm holding a mask on the patient's face. I give 100% oxygen for 3 to 5 minutes. This fills up the lungs with oxygen completely. It prevents hypoxia and desaturation. Once that is done, we start giving cricoid pressure. A cricoid pressure of 30 Newton is given, and so after the pre-oxygenation that we have done, what we have done is even given cricoid pressure. Along with cricoid pressure, we give immediately the dose of induction agent and we give the muscle relaxant, right? It is given immediately, and the muscle relaxant of choice is succinylcholine. Where it is contraindicated, we give rocuronium. Once this is done, right, you are not leaving the cricoid pressure. Within 30 seconds to 60 seconds, you will do laryngoscopy with the cricoid pressure on. After the laryngoscopy, we will intubate the patient. Once we have intubated the patient, we will inflate the cuff. Once the cuff has been inflated, it's important to inflate the cuff. Once the cuff has been inflated, this is what will prevent the aspiration. So you confirm the position that your tube is inside the respiratory system, inside the lung. Only then we will leave the cricoid pressure from here. Okay, so therefore, this is what is called as rapid sequence intubation or rapid sequence induction done for full stomach patients. So if I have to see just here in the answer, remember rapid sequence intubation or rapid sequence induction is done basically for a full stomach patient. Normally this is for a full stomach patient who is coming in for surgery, not for a full stomach patient coming for CPR. Okay, that's according to me. Therefore, when you speak of this patient, pre-oxygenation is it done in these patients? Yes, it is done. Is it a high volume, low pressure cuff used? Absolutely, a high volume and a low pressure cuff is used. Again, let me put it. High volume, low pressure cuff is what is seen in the PVC tubes which you see over here. Okay, so this is what is called as a high volume, low pressure cuff. So what happens is the pressure gets distributed along the tracheal walls. You will find the volume is high, but the pressure gets distributed along the tracheal walls. So this is the kind of endotracheal tube which is preferred. Okay, so that is what is called second option, high volume, low pressure cuff. Is it used? Yes, Induction agent muscle action given simultaneously? Yes. But is it method of choice in cardiac arrest patient? According to me, no. Some people will not agree with me. A lot of anesthesia people will also not agree with me. But that is my take on it. Okay. Anyone? Questions and doubts? So the correct answer to this question is, which is the incorrect statement? C. Method of choice in cardiac arrest patient? It is not, according to me. Thumbs up, guys. Let's go to the next question. Okay. As I said, we are discussing not just the previous year's questions. These are previous year's topics. We are discussing those topics also so that our revision is done. Thumbs up. Then we'll go forward. Okay. Okay. So the next question. Anyone? Any questions or doubts? No questions, no doubts. So, an ASA1 patient was undergoing lap cholecystectomy. It was noted that EtCO2 decreased to 8 mm of mercury, SpO2 became 90%, BP dropped to 80/50, and the peak airway pressure became 18 mm of mercury. Right? What is the most probable diagnosis from the options given to us? Is it CO2 embolism, severe bronchospasm, endobronchial intubation, or pneumothorax? Yes, guys, anyone? Just waiting if anyone would give that answer. So I can see people over here, but no one is marking the answer, right? Even if it is wrong, you can discuss. Right, so let me give the answer, guys. Okay, so ASA1 patient undergoing lap cholecystectomy, which means laparoscopic surgery is going on. So if it's a laparoscopic surgery, means yes, carbon dioxide must have been insufflated inside the stomach, correct? It is noted that the EtCO2 has decreased to 8, SpO2 has also decreased, BP has also decreased, but remember, peak airway pressure is normal. Okay. That means there are three things that have gone down. End-tidal carbon dioxide has reduced, SpO2 of the patient has decreased, and the blood pressure of the patient has decreased, right? But the peak airway pressure is normal. 18 peak airway pressure is normal. So here, guys, the correct answer to this question, according to me, right, is going to be option A, CO2 embolism, right? CO2 embolism. Right? Not severe bronchospasm, not endobronchial intubation, or not pneumothorax. In case if it's a bronchospasm, the first point is bronchospasm. The bronchus has got constricted. Pressure has increased, so therefore you'll get an increased peak airway pressure. Right? Increased peak airway pressure. Endobronchial intubation. Endobronchial. If it's endobronchial, right, peak airway pressure of course might increase and not be normal, that's one point, but more importantly, in an endobronchial intubation, it will not decrease like this to 8 mm of mercury. Same thing goes with severe bronchospasm. It might reduce it, hence I'm not discussing about there, but yes, endobronchial intubation, the EtCO2 is not going to reduce to 8, right? Similarly, in pneumothorax, it will not reduce this way. Again, the peak airway pressures will be high and it is not going to reduce to 8. The point when it has got reduced to 8, which means almost carbon dioxide is not being detected, which means almost metabolism is not taking place, which means CO2 exchange is not taking place. So therefore the correct answer to this question is CO2 embolism, right? So this is based on capnography. When we do laparoscopy, remember the stomach is insufflated with carbon dioxide. Once you insufflate the stomach with carbon dioxide, there is high chances, and that happens, that the carbon dioxide that is insufflated in the stomach gets absorbed in the bloodstream. Because it is getting absorbed in the bloodstream, it anyways increases the carbon dioxide of the patient. But in case an embolism takes place, carbon dioxide embolism, so remember that embolus goes inside the blood vessel, there's a carbon dioxide embolus, this goes over to the heart, and rather than increase, it blocks the heart over there, right? It blocks the heart. The embolus has gone to the heart. Now because the embolus has gone to the heart, The exchange is not taking place. Therefore, in a normal capnography, remember what is capnography? Capnography is that whenever carbon dioxide comes out of the lung, it gets detected over here, right? So whenever you detect a capnography detects a carbon dioxide, you will get a graph. Whenever CO2 is detected, you get a graph. Whenever CO2 is detected, you get a graph. Whenever the carbon dioxide is not detected, it is going down, which means this is inspiration. So whenever the graph is going up, it tells you expiration, this tells you expiration, this tells you expiration, and a graph going down is inspiration. So this is inspiration, 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 right? So this is expiration, inspiration happening continuously. So whenever we have put a graph of carbon dioxide, you're going to get it like this: expiration, inspiration, expiration, inspiration, expiration, inspiration, expiration, inspiration, expiration, inspiration, which means continuously IPPV is going on, which means continuous gas exchange is taking place, which means everything is normal, which means normal intubation, normal ventilation is taking place. There is no problem, everything is going on well. Suddenly you get a graph like this, which means no carbon dioxide is being detected, which means something is wrong. Either your tube is wrong or something is wrong with the ventilation. Okay, so therefore a normal capnography is when we are getting a continuous graph like this, and the value of that is almost 35 to 45, right? Normal EtCO2 value. When suddenly you find the EtCO2 value going down, it means no carbon dioxide is being detected, and this would take place normally if it's your tube, if your tube has gone into the esophagus, right? Esophageal intubation. There may be disconnection from the circuit, right? There may be accidental extubation. Something like this will also be seen in embolism or can be seen in cardiac arrest, right? So these are the things which are seen in a capnography like this, which is going down. And this was the first point given in our question, that the cases of laparoscopy where carbon dioxide is used and the EtCO2 has fallen down. What are the other options given to us, right? Let's compare them. The second option given to us is severe bronchospasm. When you compare capnography, severe bronchospasm, can you see the value of EtCO2 has not gone down? The normal EtCO2 might be around 40. If this was the normal value of 40, okay, if we look at the first graph, 40 means over here, this is the value of 40, right? 0 to 40. If this has fallen down to 8, which means no carbon dioxide detected, and this is the meaning of embolism, right? It has fallen down to 8. Now here you will find your value is 40 only, but the graph has changed. This is what is called as a shark fin appearance, and shark fin appearance is what is seen in bronchospasm, and this question was also asked recently in NEET PG, okay, previous year topics, right? Now when you say endobronchial, the next option, option C, endobronchial intubation means my endotracheal tube has gone into a bronchus. So if I put my endotracheal tube not in the lung, it has got straight away inside one bronchus. So now what happens is CO2 is coming out, no doubt. It's coming out from one end, it's coming out from other end, but there is something wrong. You are going to get CO2, but one is endobronchus, inside the bronchus, one is inside the other lung. So the next graph in capnography, would you see something like this? You remember here also it's not gone down to 8. This is what is seen in endobronchial intubation. It's gone into the bronchus. Your endotracheal tube has gone inside the bronchus. This is what is seen in endobronchial intubation, and again our EtCO2 is not gone down to 8, right? In pneumothorax, you will get an inverse slope. The slope becomes inverse. Normal endotracheal tube, when you put IPPV and then ventilation is going on, is almost like this. EtCO2 normal is like this. Normal, the graph of EtCO2 goes like this way. But if the slope gets reversed, this is a kind of thing which is seen in emphysema or pneumothorax. This is the kind of thing which is seen in emphysema or pneumothorax. Peak airway pressures are going to be high, right? Right? Peak airway pressures are going to be high, and you will find an inversion of the slope. A normal slope which is going like this, this slope becomes invert. It goes slightly down. This is called inversion of the slope, which is seen in emphysema and pneumothorax. But if you will see again, the value of EtCO2 is not gone down to 8, right? The only place where the EtCO2 has actually decreased, fallen down, it has to be when you are hyperventilating, CO2 has gone down, or there is embolism or cardiac arrest. Therefore, the correct answer to this question, we've discussed complete capnography, guys. So here is what you find. CO2 embolism to be the most appropriate answer. Severe bronchospasm would lead to a shark fin appearance. Endobronchial intubation is going to be something like this, right? You're getting two types of, your tube has gone in the bronchus, and pneumothorax would normally lead to inversion of a slope like this, right? But in no point is you are going to get a ET CO2 which has absolutely fallen down almost to zero and getting a flat line. That happens only in CO2 embolism. So the correct answer to this question is option A, CO2 embolism. Thumbs up, guys. Any questions, any doubts? So I'm waiting. If there are any questions from your side, any doubts from your side, I'll solve them out. Okay. Otherwise, we take the next question. So this was about the capnography. Yes, so let's take the next question. Which of the following agent can be used as a sole agent for induction and intubation? Option A, sevoflurane. Option B, isoflurane. Option C, halothane. And option D, desflurane. So anyone with the correct answer? Otherwise, I'll start with the option. I'll discuss the point out. Yes, guys. Anyone? So I was just waiting up. Which of the following agent can be used as a sole agent for induction and intubation? Option A, sevoflurane. Option B, isoflurane. Option C, halothane. And option D, desflurane. So the correct answer to this question is option A, sevoflurane. Right? When we discuss sevoflurane, remember, most of us already know sevoflurane and halothane, these two drugs are sweet smelling drugs. Both of them are sweet smelling drugs. Both of them are bronchodilator. Both of them are bronchodilator. Right? So sweet smelling drug and bronchodilators. So whether we speak of inhalational induction, right, or if you have to speak about a respiratory patient, in those two conditions, the drugs that we will use are sevoflurane and halothane. They can be used. But sevoflurane being a newer agent, we use it more than halothane. So when we speak of induction, right, inhalational induction, when you're using an agent for inhalational induction, remember both sevoflurane can be used as well as halothane can be used. But sevoflurane is preferred over halothane, right? Being a newer agent, faster acting, less complications. It's a newer agent, fast onset and fast recovery, and compared to halothane has less complications, right? It has less complications, so it is preferred. All right. Now, apart from that, it's also a bronchodilator just like halothane. But when we speak about intubation, what is the difference over here? I mean, a lot of you just give an answer straight away, sevoflurane be correct. But let's go behind the theory of it. What is the theory behind it? Apart from the various properties, remember I told you sevoflurane, halothane, both of them are good bronchodilator, right? They are not just bronchodilators and they relax the bronchial smooth muscles, but they are also uterine muscle relaxants, and both are also skeletal muscle relaxant. Sevoflurane has another important property. Out of all the inhalational agents, sevoflurane has the most effective skeletal muscle relaxant property. Out of all the inhalational agents, it has got the maximum skeletal muscle relaxant property. Maximum out of all of them. So it's not about just being a bronchodilator, it's not just about being a sweet smelling agent or a drug of choice for inhalational induction. Here the question has been asked that what is the drug which can be used only for intubation also. So here the correct answer would be sevoflurane. No doubt, being a sweet agent, sweet smell, being a good bronchodilator, it's a drug of choice for inhalational induction, no doubt about it. But the most important component that you would add on to it, it is a very good skeletal muscle relaxant out of all the inhalationals, even more than halothane. It's a very good skeletal muscle relaxant, which means, what is the meaning of skeletal muscle relaxation? It causes the skeletal muscle paralysis. Because it causes skeletal muscle paralysis compared to any other inhalational agent more, it can be used directly for intubation, and hence sevoflurane is the correct answer. Thumbs up, guys. All okay? And on the other hand, you will find isoflurane, desflurane both to be pungent. In fact, you will find desflurane to be the maximum pungent and maximum bronchial irritation, right? It's got maximum pungency and maximum bronchial irritation. It's avoided in asthmatic patients, in respiratory patients. Okay? Any questions and doubts, guys? Okay, so that was the answer. Here option A, sevoflurane, is the correct answer. Right, next question. If there are any doubts, please ask me. Otherwise, I'll go to the next one. Okay, so during resuscitation, a patient received intralipid 20%. What could be most probable cause of cardiac arrest? A, PEA, pulseless electrical activity. B, electrocution. C, local anesthetic systemic toxicity. Or D, asphyxia due to drowning. Yes. So during resuscitation, a patient has received 20% intralipid. Okay, during resuscitation, so what could be the most probable cause of cardiac arrest? Pulseless electrical activity, electrocution, local anesthetic systemic toxicity, or asphyxia due to drowning. So the correct answer to this question, simple, it is option C, local anesthetic systemic toxicity, okay, which is also called as LAST, last. Why? Here the patient has got 20% intralipid. So once you have given intralipid, the point is that patient must have had a local anesthetic systemic toxicity, and the drug that must have been used must be bupivacaine. Why? Because remember guys, bupivacaine is the most cardiotoxic local anesthesia drug. It's the most cardiotoxic. Remember, all other local anesthesia drugs would have CNS symptoms before the CVS symptoms, right? All the local anesthesia drugs in terms of toxicity would normally affect the CNS before the CVS, right? CNS gets affected before the CVS. So now what would happen is bupivacaine is one drug where the CVS and the CNS symptoms occur almost together, right? It's the most cardiotoxic out of all the agents which are there, most cardiotoxic, right? Here the arrhythmias would have happened at the same time as the convulsion. Point is that the cardiac complications of toxicity or toxicity of the cardiac system here becomes irreversible. Like if the convulsions which are there, as I said, convulsions happen in the CNS, arrhythmia happens in the CVS. But convulsions are normally reversible, but when we talk of the CVS arrhythmia, that is irreversible. It's difficult, it forms complexes, it becomes difficult. So what happens is the treatment of that local anesthesia toxicity is then 20% intralipid. It's a newer therapy. This intralipid is the same thing which is called as total, in what we use as lipids, the lipids which are used in total parenteral nutrition, we use the same thing. What they do, this low intralipid goes and forms complexes with bupivacaine, and then it throws it away from the body. So this TPN that we are using, 20% intralipid, which is used in TPN, when we give it to the patient, right, almost 100 ml is given, and this then would form complexes with bupivacaine and would take bupivacaine out of the system of the patient. And therefore in this question, pulseless electrical activity, no, here you will not give 20% intralipid, electrocution also, as well as asphyxia due to drowning. The place where you're using it is going to be local anesthetic systemic toxicity, which means your local anesthesia drug has gone to the bloodstream, and therefore that also the most common drug which would have caused it is bupivacaine, right? Bupivacaine toxicity. So this is the intralipid, right? This is what is normally used for TPN, and the same thing is also used for bupivacaine toxicity, right? Especially with bupivacaine. So when you speak of local anesthesia systemic toxicity, remember other drugs which can be used. So apart from 20% intralipid, what are other things which can be used for toxicity of the local anesthesia drugs? So this is the first thing. Second thing, no doubt you have to treat the convulsions, so therefore you will be using anticonvulsants and antiarrhythmics. You will be using anticonvulsants, you will be using antiarrhythmics also. And small doses of adrenaline can also be used. Remember, small doses of ADR can also be used, which is an important point. Okay, small doses of ADR. Apart from that, you have to maintain the ABC, you have to maintain the CPR, right? You have to do all that, maintain the circulation, breathing, all that, 100% oxygenation. This is without saying. This is for all medical emergencies, so there is nothing new to discuss over there. This is for all the medical emergencies which are there. Alright, so remember 100% oxygen has to be given to the patient, right? 100% oxygen. Continue with your ABC, continue with your CPR, give 20% intralipid, which is a new treatment, right? Wherever possible, as I said, nowadays people are also saying use epinephrine or adrenaline. This can be used. Okay, use epinephrine, avoid vasopressin, right? Low dose adrenaline, less dose can be used, as I said before, right? And anticonvulsants, antiarrhythmics can be used. Okay, so the correct answer to this question is local anesthetic systemic toxicity. So during resuscitation, someone has got intralipid. Why? Because it must have been cardiac arrest due to local anesthetic systemic toxicity, right? Any questions and doubts? The correct answer is option C for this question. Any questions or doubts, guys? Otherwise, we'll see the next one. Just waiting. So if you give those answers, then we'll start discussing. Or if there's any question onto your mind, we'll discuss that out. Okay. So the next question that we'll discuss, the immediate complication seen with following procedure: A, arterial puncture; B, 𝐒𝐿𝐿, C, thrombophlebitis; D, empyema. So what's the answer? Anyone? I'll wait 30 seconds. Okay, so let me start. Now the point is, the framing of this question becomes important. Even when this question was asked as a previous year question, the point is, a lot of people said, what is a specific complication seen with the procedure? Right, with this procedure, what is the most common complication seen and what is the immediate complication seen with the procedure? So first of all, we need to identify what procedure is going on. So this procedure, what you can see, is a left-sided central line insertion. Left-sided central line insertion. When you speak about a left-sided central line insertion, guys, left-sided, not on the right side. Remember, when you put a central line on the right side, and this is especially a subclavian, what you're doing, if you can see from the diagram, from the procedure, what's being done is it's going over here, right? The needle is going over here. So it is a left-sided subclavian, right? Subclavian, central line. Now, when you speak of a central line, guys, remember there is a vein where you're inserting. After the vein, close to that, we all know vein, artery and nerve. So most of the times when you're close to the vein, possibly your drug might go into the artery. It's very close, na? Vein, artery and nerve. So therefore, according to me, the immediate complication that can be seen with the procedure, ideally, or the most common seen, would be an arterial puncture. According to me, right? Arterial puncture. However, if they don't ask you immediate complication, they don't ask you the most common complication, then the answer would become 𝐒𝐿𝐿. Reason, the thoracic duct is going on the left side. Thoracic duct. So remember, when you put a right-sided central line, okay, when you're putting it on the right side, internal jugular vein, or you're putting a subclavian on the right side, a common complication that you would see over here is pneumothorax. Pneumothorax. Similarly, a pneumothorax can also take place on the left side. I'm not saying that. Yeah, so a left side you can also have pneumothorax. True. But another point is that whenever you're inserting a central line onto the left hand side, internal jugular or subclavian, so what happens is, because the thoracic duct is going over here, right? Therefore, there can be damage to that, leading to 𝐒𝐿𝐿, right? Therefore, 𝐒𝐿𝐿 will become a specific complication that occurs especially on the left-sided central line. When you're putting a left-sided central line, specifically you can get a 𝐒𝐿𝐿, right? And thrombophlebitis and empyema are out. Okay, this is something, of course, all of you would also have got confused between A and B only. So arterial puncture, according to me, is the most common complication, and 𝐒𝐿𝐿 is a more specific complication related to a left-sided central line, right? Howsoever, when you're putting a central line, because the vein and the arteries, here's the vein, the artery is going to be here only close to that. So therefore, as soon as you're inserting in the vein, it's possibly that your line might go inside the artery, your needle might go inside the artery. So therefore, arterial puncture would become a more common and immediate complication. However, it's not very specific. It's not very, not something, 𝐒𝐿𝐿 is not something which is very, very common that you'll see every time. But yes, it's a specific complication that normally takes place on a left side. So if a specific complication has been asked, according to me, the answer would be 𝐒𝐿𝐿. And if they've asked you what is the immediate complication and most common, the answer would become arterial puncture. Remember, when you put a central line, whichever side you're inserting, your central line tip lies over here, right? So you can put a central line from the internal jugular vein, you can put it from the subclavian, right? So internal jugular, subclavian, you can put it femoral, right? We can also put it basilic and cephalic, right, from the arm. These are the commonest sides, right or left. More commonly we do it from the right side, less on the left hand side, more commonly on the right. The tip of the central line lies over here, right? The tip of the central line lies at the junction of superior vena cava and the right atrium, right? There's a tip line, and that can be seen on the X-ray also. That's a way of confirming it out. Okay. Complications. All of us know there can be a hematoma, bleeding from the site, arterial puncture. So these are the commonest ones, right? Bleeding from the site, okay, arterial puncture. There can be hemothorax, pneumothorax, and on the left side there can be chylothorax. That's a specific complication, but it's not that every time you're going to get hemothorax, pneumothorax, and chylothorax. More commonly is going to be the arterial puncture and bleeding and infections, which are something that we need to be careful about. So these are the more common ones. It's not that hemothorax, pneumothorax, chylothorax happens in everyone. Okay. Also, arrhythmias may be there because the tip of the central line is lying at the junction of superior vena cava and right atrium. Apart from that, no doubt there can be other things also, migration of catheters, embolism, all of them can be there, right? But the most common would be arterial puncture, bleeding and infections, and apart from that, specific ones would be pneumothorax, chylothorax and hemothorax, correct? So this is about the central line. According to me, the correct answer to this question, if it is most common and immediate complication, is option A. If it's a specific complication, option B. Any questions and doubts, guys? Ask me if there's something. Otherwise, we'll go to the next question. Right? Alright. So, the MET equivalent of 1500 ml of oxygen consumption per minute for a healthy 70 kg adult male with basal oxygen consumption is 250 ml per minute. So the point is, they're asking what is the metabolic equivalent, okay, of 1500 ml of oxygen consumption per minute for a healthy 70 kg adult male with basal oxygen consumption, right? How much is it there? Yes, guys, is it 2, is it 4, is it 6, or is it 10? Okay, so what the metabolic equivalent is, how much? How much? Anyone? Metabolic equivalent of 1500 ml of oxygen consumption per minute for a healthy 70 kg adult male with basal oxygen consumption, alright, 250 ml per minute is how much? So the correct answer to this question is option C, 6. We are discussing about metabolic equivalent, right? Even if we forget one point over here, simple way to derive this question, they are saying we are discussing about a male, right? This male is 70 kg and his basal oxygen consumption is 250 ml per minute. This person is having 250 ml per minute oxygen consumption. Without even going into the details of the question, I'm not even going to the details, how to derive the answer. And the total consumption is how much? 1500 ml. So forget about the 70 kg point. They are saying that this male has oxygen consumption of 250 ml per minute and he is right now oxygen consumption is 1500. So what is going to be the metabolic equivalent, right? How much is going to be the METs? So basic is 1500 and you divide it by 250. Correct, answer becomes 6, and this is the METs of the patient, right? So the correct answer to this question becomes 6. But let's discuss what is metabolic equivalent and what does it state. So when we speak of metabolic equivalent, normally one MET is 3.5 ml per kg per minute. So if we have to now calculate it, this patient has 6 METs. Let's calculate ulta, right? So one MET normally, one MET is 3.5 ml per kg per minute. So if someone's weight is 70 kg, right? So you just multiply. Okay, so that is how, or 60, you just multiply it accordingly. This tells you the METs of the patient. But here in this question, what was asked is that they're already telling you how much is the consumption which is taking place per minute, and they have said 1500 ml of oxygen consumption if it takes place, how much would be the MET? So you're just dividing the amount which has been given to us divided by how much is being used, and the answer is 6. What does this MET tell us, right? This metabolic equivalent, right? What does it tell us? So metabolic equivalence basically is something which tells us about the cardiac function, guys. It's an equivalent of a predictor of cardiac function. Means someone whose cardiac function is good, right? His METs are going to be high. Someone whose cardiac function is poor, the METs is going to be low. So it's a metabolic equivalent helps us to basically classify that. It tells us the patient, for example, if someone says metabolic equivalent more than 10, it means that the patient can continuously maintain an activity which is highly strenuous, which means the cardiac function of a patient like this is good, which means this patient can undergo anesthesia without creating lot of trouble to the cardiac problems. Means the patient can tolerate the stress. The whole point is that the patient can tolerate the stress of anesthesia and surgery. Correct? That is the point. Metabolic equivalent more than 10. Now anything between more than 6, right? In this case, if it is more than 6 or 10, it's considered all okay. The problem happens when the metabolic equivalence falls to less than 4. So remember 4 to 10, remember it is safe. Anything above 4, even when we take practically speaking, a metabolic equivalent more than 4 is considered okay if you have to giving general anesthesia, or considered safe for GA. The problem happens when the metabolic equivalent falls to less than 4. If it falls less than 4, like, so that point is 4. If it falls to less than 4, which means a patient walking on the level ground cannot maintain. He can't walk on a level ground at 3 to 4 km per hour, which is highly slow walking. Okay, this patient cannot do a light household work. Metabolic equivalent of 1 means the patient can't even read properly or watch television or sit at one place. The patient can't get dressed on his own or her own, or can't eat properly. So basically, even without little movement, the patient can't tolerate the stress. That is metabolic equivalent 1. Metabolic equivalent up to 3, it means light movement also of this patient. The patient cannot, it changes the breathing pattern of the patient changes, right? Basically a light place, patient is just walking, light household work. Patient is unable to do that also, which means that the patient's cardiac function is not very good. So from every patient, when we are doing a pre-anesthetic checkup, all the anesthesia people always ask a patient a measure of their METs. We ask them about the normal activity that they can do. So this normal activity, day-to-day activity, we are asking about a day-to-day activity, right? So based on the day-to-day activity, we evaluate or predict the cardiac function of the patient. Any METs more than 4 is considered okay for general anesthesia, right? And normally we would say metabolic equivalent of 4 is when we say more than 4 METs, means a patient is able to climb one floor or one flight of stairs, right, which consists of 20 stairs, and each stair is almost 6 inches, right? I mean, according to me, that is the point. One flight of stairs, that would be around 20 stairs, each of 6 inches. If a patient is able to do that without getting breathless, without having any chest pain, without having palpitations, it means the metabolic equivalent is more than 4, and this patient can have a good cardiac function, right? The predictor is good, and he can tolerate the stress of anesthesia and surgery, and that is how metabolic equivalent helps us. Now, this point was not related to the question asked in the exam, but I was telling you the importance of the metabolic equivalent in terms of anesthesia, why this question has been asked, right? In terms of the question asked in the paper, it's very simple. How much is the total oxygen consumption? Basically, the patient is consuming 250 ml per minute. How much, they're asked, how much would 1500? If you basically he's consuming 1500 and his basal is around 250, you just divide it. The correct answer is 6. Exam purposes, simple answer. The answer is option C, 6. The METs is 6, right? But the whole discussion was regarding as to why that METs is important, right? So guys, any question, please ask me, otherwise I'll go to the next one. Yes? Anyone? Any questions or doubts, guys? Otherwise, let me take the next question. So, Next one, measurement of the nasogastric tube, right? How do you measure the nasogastric tube? Option A, from the angle of the mouth to below the earlobe until xiphisternum, from the tip of the nose to below the earlobe until the manubrium, from the tip of the nose to the ear lobule to midpoint between the manubrium sterni and umbilicus, and D, from the tip of the nose to below the ear lobule till the umbilicus. Yes. Dr. Prince Tiwari says, please explain one more time. Hi guys, Dr. Prince Tiwari, कौन सा question? Ask me which one. Good, you asked me at least. Hi Dr. Burhanuddin. Dr. Prince Tiwari, which question? METS is what you're asking. I don't mind explaining. I've been asking for ages now. Previous one says Dr. Prince. Okay. I will. Okay. Right. This one is what you're saying. Dr. Prince says. So let's go back as though Dr. Prince Tiwari wants to ask. We'll discuss that point out. Okay. So this was a question. Metabolic equivalent of. Okay. Let's put it this way. This is the question. Metabolic equivalent of 1500 ml of oxygen consumption per minute for a healthy 70 kg adult male with basal oxygen consumption 250 ml per minute is. What is the MET? Right. What is the meaning of MET, guys? The meaning of MET is metabolic equivalent. Right. What is the meaning of metabolic equivalent? Metabolic equivalent is something which tells us as a predictor of the cardiac function. It is a predictor of the cardiac function of the patient. Means just by knowing the METs, you know how much is the cardiac function of the patient. How does it help you? First, let's calculate the answer and then I'll tell you the importance. So forget about the question about what is metabolic equivalent. Just look at the question. The question is saying that we have a male and this male patient is average, right? Adult male, 70 kg is his weight, and his basal oxygen consumption, basal, routinely, he is consuming 250 ml per minute. Like every minute, what does it mean? The meaning is that in 1 minute, this person is consuming 250 ml of oxygen. That is the meaning, right? 70 kg. They have asked you that if in case 1500 ml of oxygen consumption takes place, then how much is the MET? So which means this patient in 1 minute is consuming 250 ml of oxygen, right? Now in that 1 minute, if he consumes 1500 ml of oxygen, in the same 1 minute, routine patient who was sitting at one place, I'm sitting at one place, I'm consuming 250 ml of oxygen per minute. Now I start running, I start walking, and in 1 minute, I'm consuming 1500 in 1 minute, same 1 minute. How much is my metabolic equivalent? So my metabolic equivalent would be, my METs in this case would be, let me put myself as a 70 kg pie. Okay, so I am the 70 kg person. Okay, basal oxygen consumption is 250 ml per minute, and suddenly I start running for the next 1 minute. In that 1 minute, I have consumed 1500 ml of oxygen. 1500 ml in 1 minute I have consumed, and my basal metabolic requirement was 250. So how much is my metabolic equivalent? 6, which means my metabolic equivalent is 6. So what does this indicate? The correct answer to this question is 6. But what is the importance of that 6 which has been calculated? What is the importance? The importance of that 6 is that it tells me based on the, if I tell you my metabolic equivalent is 6, so you will realize 6 means what? Can I climb a few stairs? Yes. 4 was climbing a few stairs. 4 was running a short distance. 4 was doing household chores. 4 was doing strenuous sports. If I say that my metabolic equivalent is 6, which means I can do more than strenuous sports, I can do more than household heavy chores, I can do more running and more than walking, I can be more than climbing a few stairs, maybe I can climb few floors. So this point tells us about the description of the activity level of a patient, and based on that I know the cardiac function of the patient. So if I tell someone that my metabolic equivalent is 6, the person might say yes, your cardiac function is okay. Let us take example of someone who's an old lady, someone who's a 90-year-old, like you might be knowing someone in your vicinity, किसी को जानते होगे, 90-year-old, okay, who's just sitting at one place. She's very old, she can't walk to the washroom also. The person can't go to the washroom. There's a 90-year-old grandmom who cannot even go to the washroom. That means the metabolic activity of this 90-year-old lady is just 1, which means the cardiac function of that lady is poor, because that lady cannot get dressed on her own, she can't eat on her own, even going to the washroom she will get breathless, the cardiac activity is low. So if this patient undergoes anesthesia and surgery, she might not be able to tolerate the stress of anesthesia or surgery. On the other hand, people with metabolic equivalent more than 4 can tolerate the stress of anesthesia and surgery, and therefore if someone is having metabolic equivalent more than 4, METs more than 4, patient can undergo general anesthesia safely. That's the point. Right, Dr. Prince Tiwari? So this is what explains to you about the stress, whether the heart can undergo the stress or not. So hopefully Dr. Prince Tiwari is understood. Okay, so this is a practical point which we also ask to every patient. Okay, so let's go to the next question that we are discussing. Measurement of the nasogastric tube. Okay. So option A, from the angle of mouth to below the ear lobule till xiphisternum, from the tip of the nose to below the ear lobule till manubrium, right? From the tip of the nose to ear lobule to midpoint between manubrium, sterna and umbilicus, and from the tip of the nose to below the ear lobule till umbilicus. All confusing points, right? All of you have inserted nasogastric tube. Nasogastric tube is the same Ryle's tube that we talk. Okay, same Ryle's tube. So which one is the correct answer, guys? Anyone? Otherwise I'll discuss, right? Otherwise I'll tell the answer. So there were so many people then. Any option? Anyone with the correct answer? Just waiting. Anyone? Otherwise I'll give the answer. Right. So correct answer to this question is option C. Right. From the tip of the nose to the ear lobule to the midpoint between the manubrium, sterna and umbilicus. Okay, so that is the measurement of the nasogastric tube that you are going to insert. So basically what they say, from the tip of the nose, correct, to the ear lobule to the midpoint between the umbilicus and the manubrium sterni, right? Or the xiphisternum you can take, right? I can just put it like this, right? So this midpoint is what I'm looking at. So what happens is, if you take this distance correctly, so when you're putting a nasogastric tube in a patient, it's put from the nose, right? So where your calculation has to be in such a way that it goes from the nose, right, up to the earlobe. You can see this distance over here, and after that it has to go right up till here, right? So where is this point? It has to be in the center of the stomach. So if this is the manubrium sterni, right, manubrium sterni, and this would be the umbilicus. So if this is the umbilicus, you would need a point in between that. So therefore the length of the nasogastric tube is from the tip of the nose to the ear lobule to the center of that point between the umbilicus and the manubrium sterni. Okay, so this is the correct answer to this question. Alright, so option C. Simple question, all of us already know it, but the way this has been asked in the exam, it becomes confusing to us. Alright, so the correct answer is option C, from the tip of the nose to the ear lobule to the midpoint between the manubrium sterni and umbilicus. Thumbs up, guys. Otherwise we go to the next question. Any questions or doubts? You can ask me, otherwise the next one. Right, important topic. The next one, very, very important. I think in the last 3 years, this topic in FMGE, they have asked almost 3 times. In NEET PG, this has been asked 2 times. And in INICET, almost not the same question, huh? This is previous year topic I'm talking about. I'm not saying previous year's question. All of you know, na, previous year topic is the hot thing now. We don't talk PYQs. Now people say PYT. Oh, PYT things means many other things also, huh? Okay. Here it means previous year topic. Okay. Here it means previous year topic. Okay. Anyone? What's the correct answer to this question? There is a case given of conventional mask. Okay. Conventional mask. Highest FiO2 is produced by which of the following? A patient has been given conventional mask, right? Highest FiO2 is produced by which of the following? Yes, guys. Option A, Venturi mask. Option B, rebreathing mask. Option C, Hudson mask. And option D, nasal cannula. Anyone? I'm smiling at my point only, you know. I know all of you would be thinking what is happening to me, but I'm smiling at my point only, what I was discussing. Yes, anyone? Waiting for the answers, but otherwise I'll give. Okay, so let me give the answer. Highest FiO2 is produced by which of the following? So the correct answer here is option B, rebreathing mask. A simple question, an easy question. Remember, a problem here happens that most of the people think, okay, a conventional mask is normally not a rebreathing mask. Okay, so if you have to think in this manner, that if someone says a conventional mask is a Hudson mask which is used, this is a simple face mask. So if the question becomes, or the question asked in the exam is that what is the highest FiO2, okay, by a conventional, okay, even that doesn't make sense. What is, which one gives the, not highest, or if someone asks which of the following, forget a given case of conventional mask, which of the following is a conventional mask? If a question becomes like this, which of the following is a conventional mask? In that case, guys, the correct answer would become Hudson mask, because Hudson mask is what is a simple face mask. But Hudson mask would give maximum FiO2 of only 60%. Okay, it is rebreathing mask which can give up to 90%, but it is not very conventional, in the sense not every patient is going to get be using non-rebreathing mask. Okay, so remember the correct answer to this question from the way it has been framed. Someone has been given a mask, right? Highest FiO2 is produced by which of the following? So even if I cut this point out, if I cut this which has been given in the exam, the question remains the same. Highest FiO2 is produced by which of the following? Unless until there's a link that we are missing out, because you know this is the kind of questions that we kind of see from the previous year questions as to what the students have said. Alright, so unless until we are missing out a point in between, if this is the framing of the question, then in that case the correct answer to this question becomes option B, rebreathing mask. Remember, the highest FiO2 by Venturi mask would be 60% only, with rebreathing mask is 90%, with the Hudson mask is again 60%, with the nasal cannula is 44%. So when you speak of these oxygen delivery devices, guys, remember oxygen delivery devices are classified into two types. Okay, when we speak of oxygen delivery devices, they are classified into two types. One are the low flow and other are the high flow devices. There's one reservoir also in between, but I'm not discussing that, it makes it more confusing. So let's discuss them into two parts, low flow and high flow. In the low flow, you have those nasal prongs and nasal cannula, and the maximum given by the nasal prongs is 44%. Then you have the simple face mask, which is also called as the Hudson mask, and here you will get 60% FiO2 maximum. Then you get the partial rebreathing mask 70%, and the non-rebreathing mask which gives almost 90%. On the other hand, high flow devices, you will get the high flow nasal cannula which gives almost 100%, and you have a Venturi mask. Though it is a high flow system, the Venturi mask which you see which a patient, it gives maximum of 60%. Remember, Venturi mask is more of a fixed output device. It's a fixed output device, right? So out of all of them, you will find the highest, if the option given was high flow nasal cannula, then that could give 100%. But since this option is not given to us, the option given to us was simple nasal prongs, a simple face mask, non-rebreathing, and Venturi. From these four options, the maximum FiO2 which goes in is by the non-rebreathing mask, right? If high flow nasal cannula was given, that would have been the maximum. Okay, so this about the oxygen delivery devices. So a nasal cannula, guys, remember, this is a nasal cannula, nasal prongs. This gives maximum of 44%. It works between 1 to 6 liters. A simple face mask would normally work between 5 to 10 liters, and it would give about 60% of FiO2. When you speak of a non-rebreathing mask, which has a reservoir back and a valve attached to it, and this would normally work between 12 to 15 liters and gives almost 90%, right? Here you will find the next is this is what is called as a Venturi mask. Now this is not a low flow system, this becomes a high flow system, right? Venturi mask is based on the Venturi principle, which itself is based on the Bernoulli's law. It's based on the Venturi principle, which itself is based on the Bernoulli's law. 12th standard physics, huh? All of you, Bernoulli's law, something to do with fluid, right? Small constriction is there and causes. So basically based on the Bernoulli's law, there is Venturi principle. So air goes in like this. It causes basically air entrainment. The hole which is there, it causes air entrainment. That's the point. It's called air entrainment. However, you will find the maximum still given by it is 60%. Yes, there are different percentages you can use, 24%, 35, 31, 28, 40, and the green one gives the maximum 60. The flow rate would be different for each of them, like 10 liters for 40%, you will find around 12 to 15 liters for 60%. But the maximum given is 60%. Where is this Venturi mask used? This basically is normally used for COPD patients who need fixed output. It's used over there, alright? So this is called Venturi mask. Now, so out of all the systems given to us over here, the highest FiO2 is produced by the rebreathing mask or the NRBM, non-rebreathing mask, right? Yes guys, any question? And high flow nasal cannula. This is what is called as a high flow nasal cannula. This is called HFNC, which gives almost 100%, right? 100% oxygen is given by the high flow nasal cannula. It works at 60 liters. Yes guys, any questions or doubts? 60 liters you get high flow nasal cannula. So the correct answer over here is the rebreather mask or the non-rebreathing mask. It's called the same thing. Okay, basically having a reservoir bag, NRBM. This is what is called as a NRBM. Let's take the next question. Anyone? Any questions or doubts? Otherwise, I'll go to the next one. So just waiting for the reply. Any questions or doubts, guys? Right. The question is, there is a case with image given with marked on EtCO2 value 40 millimeter of mercury. What is it? Expired oxygen, value of capnography, pressure of gases while breathing, or inspired oxygen. A simple question. It has been asked like this only in the exam also. So it was a very simple question, right? All of you already know the answer. Everything has been given there itself. Does it mean it's written EtCO2 already? So does it mean oxygen? No. Out of the way. Yes, you might get confused between two things, value of capnography and pressure of gases. EtCO2 is end tidal carbon dioxide. So basically it is the value of capnography. So the correct answer is option B, value of capnography. EtCO2 is end tidal carbon dioxide. What is the meaning of end tidal carbon dioxide? So whenever we put a monitor in front of an endotracheal tube, so whenever carbon dioxide moves out, it picks it up and it makes a graph. Whenever carbon dioxide is picked up, it puts a graph, it goes up. Whenever carbon dioxide is picked up, it makes a graph. So your graph looks like this. Okay, so that is why the capnography graph looks like this. It looks like this. Now this point which shows alveolar carbon dioxide, this highest point is the maximum carbon dioxide which is detected, and this is what is called as the end tidal carbon dioxide, right? This point which tells you the maximum carbon dioxide, okay? So this is the one, end tidal carbon dioxide. It tells you the maximum value of carbon dioxide, right? This is the maximum value. This carbon dioxide which has been picked up over here, this is what is called as end tidal carbon dioxide. The value of that normally of EtCO2 is anywhere between 35 to 40, or some books have mentioned between 30 to 40, which is almost the same as PCO2. Okay, so therefore this tells you about how much carbon dioxide has been detected in the alveolar breath of the patient, alveolar carbon dioxide. Okay, so this point is what is called as EtCO2, end tidal carbon dioxide. This point exactly what tells you is the how much carbon dioxide is being detected in the patient, which gives you a slight idea about the PCO2 of the patient. So the correct answer to this question is option B, value of capnography. Yes, any questions and doubts? Otherwise, I'll go to the next one. This was a simple question, right? It was not difficult. Okay, so if there's anything you can ask me in between, otherwise I'll discuss the next question out. How does the local anesthetic act? How does the local anesthetic act? Inhibiting the sodium channels, decreasing the resting membrane potential, activating the sodium channel, or inhibiting the nicotinic receptor? Yes, anyone? What would be the option? What would be the answer to this question? Yes, guys. Anyone? What does it do? So the correct answer to this question is option A. It inhibits the sodium channel. Does it activate the sodium channel? No. Does it work on the nicotinic receptor? No. It's not inhibiting the nicotinic receptor. And is it decreasing the resting membrane potential? No. Nothing of that sort. Okay. Not over there. Basically what it is doing is it is inhibiting or blocking the sodium channels. When we speak of local anesthesia drugs, right, whenever you give local anesthesia, what happens is you are injecting local anesthesia inside the tissue, and from the tissue it gets absorbed inside the nerve. So when it gets absorbed inside the nerve, so the same nerve which we have seen, the nerve basically carries the action potential, right? So the action potential propagates like this. So sodium goes inside on the sodium channel, right, and the action potential jumps to the next one. Sodium goes inside, action potential jumps to the next one. Sodium goes inside, action potential jumps to the next one. Can you see that is how action potential is getting propagated and moving forward? So action potential is moving forward. But once you inject local anesthesia drug, so what happens is local anesthesia drug, when I've injected, it goes inside, right? Once I inject local anesthesia drug, it penetrates inside the cell, inside the nerve. It goes inside, local anesthesia has been injected, it goes inside. Once inside, it blocks the sodium channel. So you see, it has gone and it has blocked the sodium channel. So my local anesthesia drug has gone and blocked the sodium channel, right? So local anesthesia drug, because it has blocked the sodium channel, now you will find that the action potential does not go forward. It has got stopped here itself. So the action potential, because sodium was supposed to go in, but because the local anesthesia drug has blocked the sodium channel, now the sodium which was supposed to go inside does not go inside. Therefore, the action potential which was supposed to move forward from there, right? Action potential came over here. It was supposed to move like this. But because we find that it has been blocked, sodium channel has been blocked, right? Basically what it is done, it's inhibited the channel. Is it activating the channel? No. The channel is now inhibited. It is not activating the channel. This sodium channel is where it's working, and this sodium channel has got blocked. So when we speak of the local anesthesia drug, guys, remember local anesthesia drugs works at the nerve, it works at the nerve fiber, and basically what it is doing is that it blocks the generation and conduction of impulse or action potential. It blocks the generation and conduction of impulse or action potential, right? It prevents the action potential from moving forward, right? And because of that, where is it working on the nerve? Then it's working at the sodium channels. Remember, not just the sodium channel, it can also work at the potassium, calcium and chloride channels, but the maximum effect takes place at the sodium channel, right? Maximum, not that it can't work at the other channels, right? It can work at the potassium, calcium and the chloride channel also, but the maximum effect is what is taking place at the sodium channel. So how does the local anesthesia act? Remember, it inhibits or it blocks the sodium channel, and that too it blocks on the intracellular slide. It goes inside and blocks from within, right? That's the point. Also, it blocks the voltage gated sodium channel more than the other types. The voltage gated sodium channel, right? Voltage gated sodium channel is what gets blocked. Alright guys, so the correct answer to the question is option A, inhibits the sodium channel. Any questions and doubts, guys? Otherwise we'll take the next one. Yes. Any questions or doubts, guys? Okay. So the next question is here. What is the most common cause of hospital admission after daycare surgery? Option A, PONV, which is post-operative nausea, vomiting, surgical site pain, blood pressure or respiratory problem. Yes, anyone? Again a common question, daycare surgery. Recently they've concentrated on that also. Anyone with the answer that would like to suggest? Right, so let me go forward. According to me, again, when I say answers to these questions, these are all those controversial questions, right? Controversial questions, as always, because INICET, when you speak about NEET PG, many times you find those controversial questions every time in the paper. One controversy because everyone will say lot of teachers also might have the thinking which might be different. The textbooks also have different answers. A question like this is not given directly in the textbook. None of the textbooks give you the answer which is the most common cause of hospital admission after daycare. Normally it's not given. No book writes like that. They say, yeah, commonly occurring side effects that can take place, common causes that can take place after surgery, after daycare surgery. According to me, the correct answer here should be post-operative nausea, vomiting from the admission, from the options which are given to us. So the point is, daycare surgery has been done. A daycare surgery means the patient gets operated during the day and the patient is supposed to get discharged on the same day, right? Same day surgery and same day discharged. But what is the reason because of which the patient has been asked to get admitted? Is it a surgical site pain? If there's a surgical site pain, you will give more medicines to take care of the pain and analgesic and take care of it, right? Blood pressure, hypertension is something is happening. Yes, it might take place. I'm not denying. Okay. Respiratory problem, the patient will go straight away in the ICU and oxygen and all those things. But they're not asking what are the things. Can all these reasons be one of the reasons for an hospital admission? Yes. Surgical site pain, yes, it can be a cause of admission. Changes in blood pressure, yes, it can be a cause of admission. Respiratory problem, yes, patient can go to an ICU also because of that. But the point is not that. They're asking you which is the most common cause of hospital admission after daycare. Means the most common. A normal patient who's been getting operated. And normally he should have got discharged. But why are you keeping him? Because he's got so much nausea, vomiting that he can't go home. You've given medicines and he can't be discharged. So when you look at the complications that take place, the maximum anesthetic complication, in fact they say the maximum anesthetic complication after daycare surgery is post-operative nausea and vomiting. This is the complication which takes place maximum. Apart from that, you also get drowsiness, dizziness, which means the same thing like sedation. Patient is sedated a lot. So all these are complications. If someone will have to ask me, what are the complications that normally take place in a daycare surgery, right? If someone says, what are the complications that take place in a daycare surgery? Normal, I'm talking maximum, not discussing each one of them. So one of the things that stands first would be post-operative nausea, vomiting. The second would be drowsiness, sedation. And remember, drowsiness and sedation can lead to respiratory problems. I'm not denying that. If the patient is highly sedated, drowsy, there can be respiratory points. I'm not denying that. Post-operative pain. And remember, surgical complication. So according to me, the maximum complication that takes place is a post-operative nausea, vomiting, and that's why in a daycare surgery we try to avoid using drugs which can cause post-op nausea, vomiting, like nitrous oxide. We'll not try to give nitrous oxide. It causes a lot of post-op nausea, vomiting. Etomidate, right? Etomidate, maximum nausea, vomiting. So these two are the maximum nausea, vomiting post-operatively, inhalationals as well as IV. We'll try to avoid these drugs. We want to use drugs which are not causing, in fact all the inhalationals also causing a lot of nausea, vomiting, and that's why the concept for daycare surgery has come out to be TIVA, total intravenous anesthesia, a question which has been asked, where we give only IV drugs, right? Because we are trying to avoid all the inhalationals also. That's why you want to give fast acting IV drugs. Patient can go home the same day and not have nausea, vomiting, because this complication takes place maximum in most of the patients. Yes, there is drowsiness, there is sedation. Based on that, there can be respiratory depression, post-op pain. Now, for this question, the correct answer for me would have been post-op nausea, vomiting. The patient is having so much nausea, vomiting that the patient can't be discharged. But if the question is asked like this, that what is the most common cause of readmission? Readmission means the patient has been discharged and then he has got readmitted. Saw the difference between them? Here the question is, what is the most common cause of hospital admission after daycare? Means he was not discharged. This means the question which has been asked means it has not been discharged. But the point is, if someone says what is readmission, a patient has been discharged and he gets readmitted again. In that case, the correct answer then from me would be surgical complication. Because if it is a surgical complication, if it is nausea, vomiting, imagine I've discharged the patient and he still has nausea, vomiting. He's gone home. I'll say, oh, you take 2 more medicines. If he's slightly having pain, I'll tell you take 2 more medicine. But if someone calls me up and says, me or the surgeon, that I've got bleeding from the surgical site, in that case, I'll tell, oh, run to the hospital, get readmission. So for me, the correct answer for a readmission after discharge would be surgical complication, and normally to get admitted would be the most common complication that takes place, which is nausea, vomiting. Remember, the point of a daycare surgery is to do small surgery, and the most important point is that minimal risk of post-op complication should be there, right? Simple, you have to take care that a lot of pain is, you're not doing very major surgery, right? The patient must not be immobilized for long and should be going home, right, immediately. The point is, if the patient is unable to ambulate without dizziness, the patient is having nausea, vomiting, right? So this is exactly what happens in post-op nausea, vomiting. If there is post-operative nausea, vomiting, his ambulation would become difficult, right? His dizziness is not going to let him walk properly, right? And he's continuously throwing up the vomiting part. So this is the reason why I'll tell you, don't go home, sit there, right? Be in the hospital. If there is pain, what I can do, I can add analgesic. But if he is having continuous vomiting, I'll rather have him observed in the hospital, and this is the most common or the maximum complication that takes place, and that is why the correct answer, according to me, for that question is going to be nausea, vomiting, post-operative nausea, vomiting, the most common cause for a hospital admission after daycare surgery, right? Thumbs up, guys. Any questions or doubts? So option A was the correct answer there. Yes, guys, any questions, any doubts? Okay, so let's take the next question. There is a given image of a green cannula. What is the number or the gauge? Okay, what is the number or the gauge? So green cannula is 20, 18, 14 or 22 gauge. Simple question. The correct answer to this question is option B, 18 gauge. These questions are being asked. They are important ones, and you have to keep in mind that these questions are simple. They don't need lot of studying. These are practical points which you people already know. But yes, at the time of exam, you need to recollect them. Remember, the most common cannula which is used in adults is the 20 gauge. I've discussed this point out, right? The blue one is 22, the yellow one is 24, right? There's another one which is purple in color, right, which is 26 gauge. Remember, the most common used in adults is pink. The blue one is used in adult or used in pediatric. The yellow one is used in neonates, and the purple one is used in preterm neonates, right? Preterms. And when you speak of 14, 16 and 18, these are the ones which are used for fluid or blood resuscitation. Right? So these ones that you find, these are basically thin gauge, and these ones that you find are basically thick gauge. So thick gauge are the ones which will be used for your fluid and blood resuscitation, and the thin ones which are used basically for pediatric patients or neonates. Now, there's one method, not mine, but I found it to be easy for people to remember, and of course it's not mine, right? People do make their own, but why should I take someone else's point of view if someone else has made it? But yes, it was suggested to me by one of the students, and remember it as a purple galaxy, right, which has a yellow sun, right, and then there is a blue sky where there is a pink flower, right, and has a green leaf, which is on a grey ground and has orange lava. Nice image. It's a good image based diagram, so I'm not sharing that, right? I don't have it, but this is how students had suggested. Very nice way to remember. So this tells you about the various colors, and you can remember them accordingly. 26, 24, 22, 20, 18, 16 and 14, the gauge of the cannula. The flow rates are also important. Remember 54, so 50 to 54 is for the pink one. If you will look at the green, grey and orange, they become respectively they'll become 80-200, 180-200 and 270-300, and the smaller ones would be 33 and 20. Okay, so this is the flow rate in ml per minute for the IV cannula. Important question. Next question. Identify the equipment used below. Yes. So is it A, nasal cannula? Is it B, non-invasive ventilation? Is it high flow nasal cannula or continuous positive airway pressure? Yes, anyone? Just waiting if anyone would give the answer. Simple question, right? Okay, so identify the equipment used below. A, nasal cannula, B, non-invasive ventilation, C, high flow nasal cannula, or D, continuous positive airway pressure. So the correct answer to this question is option C, high flow nasal cannula. Is it a normal nasal cannula? Yes, it looks like a nasal cannula. The only confusion that you'll have is between nasal cannula and high flow nasal cannula, right? Non-invasive ventilation is the same place that you will find as continuous positive airway pressure. Okay, so here the correct answer that you would get confused is between nasal and high flow nasal cannula. So remember, you can see a humidifier, right, which is attached to the oxygen over here. The presence of the humidifier and a bigger tubing right? It's not a small flow meter tubing which you see. So what's the difference in a nasal cannula? A nasal cannula, if I have to discuss, will show you. So here is the nasal cannula. Here is the normal nasal cannula. Can you see the oxygen pipe which connects the flow meter to the patient? This oxygen pipe is a thin one. It's not a thick one. However, when you speak of a high flow nasal cannula, can you see this is a thick pipe? This oxygen pipe is thick. If you will see the oxygen pipe which you see over here, it is thick. I'm trying to make it as simple as possible in terms of explanation of pipe, the way I'm saying. Okay, so you'll find this to be thick, right? Similarly, you'll find this to be thick. This is thick and this is thick, right? Compared to a normal nasal cannula, which is thin. This one is thin, right? So therefore, what you can see over here is this thick tubing. You can see a humidifier. So presence of this thick tubing, right? This thick tubing that you see, and the presence of this humidifier that is attached to the oxygen flow meter is what makes you identify it as the high flow nasal cannula. Okay, and remember, high flow nasal cannula can give 100% oxygen. Maximum flow rate here that you get is 60 liters. Okay, so important point, I've already discussed this before when we are discussing oxygen delivery devices, right? We've already discussed this point in the oxygen delivery devices, that there are two types, low flow and high flow. So the low flow consists basically of the nasal prongs nasal cannula, which give maximum of 44%. Followed by that, you have a simple face mask, a Hudson face mask. This gives 60%, and you have a non-rebreathing mask, which gives almost 90%. Right? Then you have high flow nasal cannula, which gives almost 100%. Okay, and you have a Venturi mask. The maximum, however, is 60%. Right? So here what we are seeing is a high flow nasal cannula. Remember, it can give 100% oxygen to the patient. Okay, so this is high flow nasal cannula. Next point, important one. Remember, always a question is going to come regarding CPR. Always. There's no doubt that you will not get a question based on it. Some question or the other is definitely going to be there. A 45-year-old male is found unconscious on the road. A thorough assessment reveals that the patient has a cardiac arrest. If you handle such a patient at the event site, which of the following guidelines would be your first step in managing such a patient according to the ACLS guidelines? Option A, check carotid pulse, CPR, call for help, shock if available. B, call for help, check pulse, do CPR. C, observe. D, just CPR. Yes, anyone? What would be the correct answer to this question? Yes. So 45-year-old male is found unconscious on the road. A thorough assessment has revealed that the patient has got cardiac arrest, which means there is no response, there is no pulse, there is no breath. you are handling this patient at the event site. What would be your first step in managing such a patient? Right? So what will you do? At the site, what will you do? Yes, anyone? Yes, anyone? Any answer? Option A, option B, option C, or option D? So the first thing, let us cancel them out. The patient is lying unconscious. A thorough assessment has revealed the patient has cardiac arrest. Would you just observe? No. You would not observe. Option C is out. Right? Check for carotid pulse, do CPR, call for help, and shock. The point is, you will check carotid pulse, no doubt, but call for help basically comes before checking the pulse. If that would have been there, it could have been a correct answer. So option A is again out. Okay, option A is again out. You have two options left with you, right? Two options left with us. So option A is out and option C is out. Option B is call for help, check pulse, do CPR. So ideally this is correct. Option B, call for help, check pulse, and do CPR. Right? This is correct. It is not wrong. But if you read the question correctly, it has been mentioned that the patient is lying unconscious, which means there is no response. Right? A thorough assessment has been done, right, which has revealed that the patient has cardiac arrest. So just realize what the statement is saying. The statement is saying that the patient has already had a cardiac arrest. Assessment has been done, which means there is no response, which means there is no pulse, which means there is no breath. This has been done. So in this case, what would be the correct answer? So therefore, I will straight away start CPR. According to me, I will start CPR. Yes, if the question is framed in some other way, in that case, remember the correct answer would be B. Call for help, check pulse, and do the CPR. But if they have done a thorough assessment and which reveals a cardiac arrest, it means the pulse has been checked, which means you must have already called for help, which means in this case I will start CPR. Right? If I take, imagine the same sentence is given like this. If the same question is framed in another manner like this, I am telling you how the questions come in the exam, and you know how do you attempt such things. A 45-year-old male is now found unconscious on the road. You are handling this patient at the event site. Which of the following would be the first step in managing such a patient according to ACLS guidelines? Now, in this question, we have cancelled out this statement. I've cancelled out the second statement. 45-year-old male unconscious on the road. You are handling the patient. What would be your first step? In this question, my correct answer straight away becomes B. Straight away, without even looking at anything. Call for help, check pulse, do CPR, straight away. But if I take into consideration the second statement, which means patient is found unconscious, I have done an assessment. A thorough assessment has been written, which means I've checked the response, I've checked for pulse, I've checked for breath, and that assessment has revealed that there is cardiac arrest, which means now there is no response, right? There is no breath and there is no pulse. So when there is no response, there is no breath, there is no pulse, what is the next step? CPR. So therefore the correct answer for me would then be CPR and not option B. That is my way of dealing with this question, or my way how to answer this question, right? Thumbs up everyone, is that okay? The correct answer would be just do CPR. So what are the guidelines, guys? You need to know the guidelines then. So as I was saying, these are the guidelines that you see, and all these questions have been asked in INICET also, and NEET PG as well. The first step is always scene safety, that the scene is safe or not. The second step is check for response. So this is the second step. So if the response is there, leave the patient. If there is no response, the third step is call for help. So you see, the first step is scene safety, second is check for response, third is to call for help. When you call someone for help, you are getting the automated external defibrillator, you are getting someone to help you out, they'll get the emergency equipment. Till now you have not checked for breath and pulse. Scene safety, check response, and call for help. Now once you've already called for help, then you look for breath, then you look for pulse, right? Where do you look for breath? I look for breath by looking at the visible chest rise. You know whether the chest is rising or not. The patient is lying, I'm looking at the visible chest rise. The pulse normally that is felt is carotid, right? You will feel the carotid within 10 seconds. If you feel that the chest rise is there, I can see the visible chest rise, I can feel the carotid, keep the patient in the recovery position. That's the next point. Both of them are there. Keep the patient in the recovery position. This question was also asked last year. This is a previous year question. Okay, not image based diagram. I think yeah, it was an image based diagram, NEET PG, if I'm not mistaken. Now, second point is that patient has visible chest rise. No. Patient has carotid pulse, but patient does not have a visible chest rise. Patient does not have a visible chest rise. In that case, what to do? You come to option B. So the first option was both are present. You keep the patient in recovery position. Option B, in this case, you are feeling the pulse, but chest rise is not there. So what is missing? Breath. In this case, you will give the breath. So you give the rescue breathing. One breath is given every 6 seconds or 10 breaths per minute, and keep on checking the pulse every 2 minutes. Right? This is option B. Option C, there is no chest rise, there is no pulse, which means you start CPR. This was the question. According to me, start CPR, because they have already assessed that the patient does not have pulse, the patient does not have breath, there is no response, which means they have already confirmed that there is a cardiac arrest. So they have already checked for response, breath and pulse. So in that case, I will not mark the option B, because option B means I have to check the pulse. If you have to check the pulse, then how do you know that cardiac arrest has taken place? Right? And they've also mentioned that thorough assessment has been done. So if they have done a thorough assessment, they have given you that there's a cardiac arrest, then this point does not stand valid. You will straight away start CPR as what has been given in the chart according to me. I may be wrong. I'm just sharing my knowledge and how I will come to this question. How will I derive this question or come to the options? Right? That is my point of view. So I will straight away start CPR over here, and option B according to me would not be correct, as if this sentence was not given. A thorough assessment reveals that the patient has cardiac arrest. If that is not given, then the option B is correct. But if they have given this sentence, for me the answer will be option D, start CPR. Right? Once you start the CPR, remember it is chest compression, airway and breathing. Again, important point, when you give chest compression, it's lower 1/3 of the sternum, 100 to 120 chest compressions per minute. It is 2 to 2.4 inches or 5 to 6 centimeter, and allow for the recoil of the chest. Next is airway, CAB, airway. What do you do for the airway? Head tilt, chin lift, jaw thrust has been asked in the exam, right? So you have to do head tilt, chin lift or jaw thrust. Sometimes people call it a triple maneuver also. This image was also asked in the exam, recent exam. Okay, so these are all previous year question, not even topic. Previous year question. Topic we are discussing, but it's a topic as well. So head tilt, chin lift, jaw thrust. And after that you start with the breath, right? So keep on giving breaths to the patient. Always give 2 breaths. Inspiration over 1 second, expiration over 1 second. Look for the visible chest rise and no excessive ventilation. So that's how you give the CPR. You're supposed to do those cycles of 30:2 as it has been mentioned. So head tilt, chin lift basically opens up the airway, right? And then CAB is to be continued. We are going to perform cycles of 30:2, 30 chest compression, 2 breaths. We are continuing the CPR till the time we get AED, automated external defibrillator or a defibrillator. As soon as you get a AED, attach the pads, check for the rhythm, right? If the rhythm is shockable, you give the shock. Remember, after the shock, no pulse check. Straight away start your CPR, right? Straight away start your CPR, and once you finish off your cycles of 30:2, then check the rhythm again, right? If your rhythm is again shockable, give the shock. Of course, you give the shock. After the shock, no pulse check, straight away start CPR, right? After doing the CPR for 2 minutes, then again check the pulse, right? You will continue till the time ACLS people come or the victim starts to move, or 30 to 40 minutes of good CPR is when you declare. If when you're on the rhythm that you find it's a non-shockable rhythm, in this case, you're not supposed to give a shock, so that's out. So why will you do pulse check also? Immediately start CPR, correct? Same thing, start your CPR for 2 minutes, and after the 2 minutes, then again check for the pulse, and therefore by then you will have to wait for if the ACLS providers are coming or not. If not, you check for the rhythm again. If the rhythm is again non-shockable, you will not give a shock and resume your CPR for 2 minutes, check the pulse. and again go back. Okay, so that's how it keeps on continuing for 30 to 40 minutes. What are the shockable rhythms? The shockable rhythms are pulseless ventricular tachycardia and ventricular fibrillation. Now this becomes ACLS, right? And the non-shockable rhythms are going to be pulseless electrical activity and asystole, right? When you speak of ACLS now, you can use drugs, guys, right? When you speak of ACLS means advanced cardiac life support. So you already have an airway. So you already have an endotracheal tube, you have a laryngeal mask airway, or something has been inserted in the patient to take care of the airway. Remember? So once you're doing ACLS, so you are not, if you put an endotracheal tube inside the patient or a laryngeal mask airway inside the patient, remember that 30:2 does not stand anymore. Rest all things remain the same. You can check the monitor the pulse, monitor your CPR by EtCO2, right? The shock which you give in case if it is needed, biphasic defibrillator will give 120 to 200, monophasic will give 360. The drugs that you can use: epinephrine, amiodarone, lignocaine, magnesium. 4 drugs. Apart from that, nothing else is used. No other drugs are used. How will you give it? You remember, when you say ACLS, you will always have an IV access. If IV access is difficult or you're not getting it, remember, intraosseous access is important. Intraosseous, even this question has been asked in NEET PG, or if I'm not mistaken, NEET PG. Intraosseous. A diagram has been asked regarding intraosseous cannula. Intraosseous, the most common is the tibia and the humerus, right? Upper end of the tibia, there is humerus. Anterior superior iliac spine, you can take it on the sternum also, right? So intraosseous access becomes very important in emergency when you're not getting an IV cannula, and you can use adrenaline, amiodarone, lignocaine, magnesium. Only 4 drugs, rest nothing is used from there, right? And you have to keep on thinking about the 5H and 5T. That is about the ACLS, guys. Any questions and doubts, please ask me. Otherwise, we'll take the next question. Yes. Any doubts, guys? So we discussed BLS, ACLS. Any questions or doubts? No doubts. So I'll go forward. Okay. I was just waiting in case anyone wants to ask something, because this is an important topic. Okay. Alright. So the question is, a 15-year-old boy presented to the emergency department with difficulty breathing after being stung by a bee. On examination, lung wheezes are heard and his lips are swollen. Blood pressure is 80/55 mm of mercury. Epinephrine is injected as a part of management protocol. What is the correct route and concentration of ADR given to such a patient? Intramuscular 1:1000, intravenous 1:10,000, subcute 1:1 lakh, epidural 1:2 lakh. Yes, anyone? A good question, important question, and a simple question. Yes, guys, what would be the correct answer to this question? So what we have is a 15-year-old boy. He is presenting to the emergency. There's a difficulty in breathing, right? He has been stung by a bee. Lung wheezes are being heard, right? And lips are swollen. The blood pressure is 80/55, right? Epinephrine is injected. So basically, after a bee sting, there is the problems that you can see: wheezes, bronchospasm, lung wheeze, lips are swollen, blood pressure is 80/55. This is not cardiac arrest. Correct? The point is, this is not cardiac arrest. Had it been cardiac arrest, remember, most of you would have thought, then the correct answer becomes intravenous. In case of a cardiac arrest, straight away you have to give intravenous ADR 1:10,000. This is cardiac arrest. But here it looks more like anaphylaxis, right? When we speak of anaphylaxis, the point is 1:1000 in anaphylaxis, and that is given intramuscular, right? So therefore, for me, the correct answer to this question would be option A, to give epinephrine or adrenaline, which is given 1:1000 intramuscular. Had it been cardiac arrest, I would have given intravenous 1:10,000. Remember, that's what I discussed right a while back. ADR is given intravenous or intraosseous. We did not mention intramuscular over there. When there is cardiac arrest, guys, remember in cardiac arrest you are supposed to give IV or you will give intraosseous. That is the route of administration which we just saw. So if you have to see, look at this. Here you will find here itself. Where is it? Yeah. Epinephrine is given IV or intraosseous. Amiodarone is given IV intraosseous. Lignocaine is given IV intraosseous. These are the ACLS guidelines, management protocol. Okay, ACLS guidelines, intravenous or intraosseous. They haven't given intramuscular, right? So had it been cardiac arrest, you would be giving intravenous 1:10,000 cardiac arrest or intraosseous. So here what they are saying is anaphylaxis, what you're expecting. The patient has been stung by a bee, right? There is difficulty in breathing. Of course, there is lung wheezes which are heard. The lips are getting swollen. The blood pressure is 80/55. Anaphylaxis is what we are expecting. Epinephrine has to be given, right? But here you will be giving it intramuscular 1:10,000. This is what is used in anaphylaxis. Subcute 1:1 lakh. No, that is not used. In epidural 1:2 lakh. Yes, it can be used, but not ADR and not for this condition. In epidural, definitely we use lignocaine, but it's not ADR alone. Remember, in the starting of the discussion, we said that most of the local anesthesia drugs are vasodilators. So you normally have lignocaine plus ADR or phenylephrine, as I was telling you, and lignocaine plus ADR can definitely be used, and there the ADR is 1:2 lakh. I'm not denying, okay, it's used over there, right? So therefore, in epidural, lignocaine plus ADR can be used, but it is not for anaphylaxis, no. It is not for anaphylaxis, that is to give local anesthesia. Similarly for subcute, right, 1:1 lakh, are you using it? You can. I mean, if it's a plastic surgery case or something going on, they can use. I'm not denying over there. If they're using it for plastic, they're also, they prefer to use 1:2 lakh. But if they're using it in plastic surgery, they know their concentrations better than me, but yes, they can. But intramuscular 1:1000 is what will be used in this condition. So here what I'm expecting is anaphylaxis. So anaphylaxis, the correct route or mode of administration would be intramuscular, right? 1:1000, and that is what is being given as option A in the question that has been asked. So the correct answer to this question is option A, intramuscular 1:1000. Yes guys, any questions or doubts? Otherwise I'll go to the next question. Yes, anyone? No doubts? Let's take the last one. Okay, so that's the last question from the previous year's question that we are discussing. So these questions were right from 2020 to 2022, right? To 2022. So this is the last question. Blue pipeline in OT is for which anesthetic gas, right? Blue pipeline in the OT is for which anesthetic gas? A, oxygen, B, nitrous oxide, C, air, or D, vacuum. Anyone? Yes guys, anyone? What is the correct answer to this question? A blue pipeline is in the OT for which anesthetic gas? Dr. Yul Paul says B. Correct. Yeah, nice. So B. So let's say, what is the color of vacuum then? Anyone? So nitrous oxide is blue. Correct. Absolutely correct. So what is vacuum? Which color? Important points, huh? So all these are simple but important, right? So we discussed all these questions right from 2020 to 2022 from anesthesia, whatever came in INICET. So this was the last question that we are discussing. Yes, anyone? So remember, oxygen in pipeline is always white in color, nitrous is blue in color, air, Dr. Yul Paul says yellow. Absolutely correct and very good, right? So this is yellow in color and air is black in color. So remember, when we speak of pipelines, so pipelines, when they come, they are attached, they are spread all over the hospital, right? So these pipelines, two important questions. One is the color, which has been asked in the exam, and second is to prevent the wrong pipeline attachment, what is called as a diametric index safety system. Diametric index safety system. These 2 points are important regarding the pipelines. The pipelines belong to the intermediate pressure system, right? And when you attach them onto the wall mounts, something like this. So what happens if this is oxygen, this is nitrous? So as you can see, white color is oxygen, blue color is nitrous, right? Black color is air, and here yellow color is vacuum. So if I want to interchange either of them, I can't change them because there is a system of diameters. It is based on a system of diameters. You don't need to know the diameter, but based on the diameters you can't interchange them, and that is what is called as a diametric index safety system. So what does the diametric index safety system do? So diametric index safety system, basically it prevents the wrong pipeline connection or wrong pipeline attachment. It prevents the wrong pipeline attachment, right? So this is also basically intermediate pressure system. All right, so apart from that, remember, color of the cylinders become very important. So they are asked in the exam. So remember, cylinder of air, oxygen, nitrous, NOx, carbon dioxide. Air has got a lot of changes. Initially, when we were teaching and all, we were saying gray with white. But now the problem is, a lot of places you will find it as black with silver. Sometimes some places has been mentioned gray with black. So remember, this air is now a question mark, big question mark. Okay, this air is a big question mark on nomenclature. Okay, so you have to be careful with what has been given in air regarding the color. So normally we have all studied gray with white, but yes, nowadays it is coming black with silver also. It might be gray with black also, right? Oxygen is black body with white shoulder. Okay, black body with a white shoulder. Nitrous, guys, is basically blue in color. NOx is blue body with white shoulder. So this is basically the white shoulder. Carbon dioxide is grey in color. When we speak of pin index, remember, air is 1.5, oxygen is 2.5, and nitrous is 3.5. These are the most important. First three are the most important, 1, 2 and 3. NOx is 7, right? And carbon dioxide is 1.6 or 2.6. That depends on the percentage of carbon dioxide which is there in the cylinder. So these are the 5 most important cylinder, the colors as well as the pin index. As I said, be very careful in case a cylinder of air is coming, because nowadays a color coding of that has been changed. Even practically speaking, initially in our hospital also, practically speaking, I used to get grey with white in color. In my hospital now I'm getting black with silver color, right? Black with silver shoulder. But some people are saying it can be grey with black. So nomenclature, color of air has changed, even practically speaking, not just theoretically. Okay, so this was regarding the cylinders and the pipelines, the colors which are important. And the last I'll discuss over here is the color of the the color of the vaporizer. So remember, halothane is always red in color, right? Enfluorine is orange in color. Isoflurane is purple in color. Desflurane, it's light blue in color. And remember, desflurane vaporizer is different. This is the one which is electrically heated. This was a FMG question recently. Okay, it is electrically heated because desflurane boils at 23 degrees or room temperature. So therefore, the desflurane vaporizer is a special vaporizer. It's a special vaporizer which is called as Tech 6. The name is not important, forget that, Tech 6, but remember, it's a special vaporizer which is electrically heated. And then you have sevoflurane, which is yellow in color. So we have discussed the colors of IV cannula, colors of all the vaporizers, colors of the cylinders, and colors of the pipeline. Right, guys, any questions and doubts, please ask me. I've discussed all the questions, most of the questions from 2020 to 2022 that we could lay our hands on. Okay, so this was a complete revision that we've had. Any questions and doubts, guys, please ask me. So anything that you want from my end? Yes, anyone? Yes, guys, any questions, any doubts? I think that was the last question according to me. Yes, that was the last question. Any questions, any doubts? My Telegram ID is Dr. Vinish, DRVINISH. Okay, you can get in touch with me. Any questions and doubts, you can ask me directly. Right? Any questions, any doubts right now? Otherwise, my Telegram ID is Dr. Vinish, DRVINISH. That's my Telegram ID. Right guys, anyone? Any questions, any doubts? नहीं किसी कोई question कोई doubt नहीं है? Okay, so we'll end the session then guys. Still there are people around. Yes, कोई कुछ पूछना चाहता है तो पूछ लो भाई. Otherwise, all the best guys. Do well. Okay. It's all about smart studies and revision. Okay. INICET also, as everyone says. Just remember, it's about smart studies. Right. Thank you, Dr. 𝐒𝐿𝐻𝐿. Any question and doubt, Dr. 𝐒𝐿𝐻𝐿? या कोई भी और भी जो लोग हैं, please यार कुछ पूछना चाहते हो तो पूछ लो. All the best guys. You guys do well. ठीक है. It's about keeping your nerves, just like a cricket match. You need to keep your nerves. Okay. Smart study. That's important. Which you must have already done. But now, the amount of time that is left, it's about revision. How fast can you do the revision? Okay? How fast can you revise is what is important. And remember, it's revision of not one subject. You need to revise all 19 subjects. So all the important points you need to revise. And according to me, yes, you must have already made out your notes. You're preparing for INICET, important exam, right? So you already must have had all the important points. But remember, don't neglect any subject. All the 19 would be important. All the 19 would be important. So just flip over the pages and try to see that the revision has been done. Okay. So thank you for joining me at the session guys, and all the best. Do well. For sure you'll do it. Okay. And once you're done, let me know. My Telegram ID is over here, Dr. Vinish. Any other questions that you want to ask from anesthesia, you can ask me directly. I'll try to solve them to the best of my knowledge. It's not a channel. This is my Telegram ID where you can get in touch with me. Thank you guys. Thank you so much. Okay. Thank you. All the best. Do well.